You know that this course is about research and quality improvement and program evaluation, but you might be confused at this point still about what the differences are between those terms. If you find yourself in that boat, don't worry, we're there ourselves some of the time. I think we are learning more about how people interpret these and what the regulatory environment looks like. These are essentially legal terms or terms of practice that get used to talk about the types of activities people do and to draw distinctions between them. So, in my opinion, there aren't real distinctions. They're more rules of thumb or gradations between them that are important from a regulatory perspective, and we're going to give you some of those today. Usually when I give this kind of a talk, people ask me to start with the definitions. I think if we could define the terms clearly, we wouldn't have this problem. Unfortunately, these written definitions come from some of the best sources available. The one about research comes from the Federal Register, the authorizing legislation for human subjects review boards. The one about program evaluation comes from the National Evaluation Association. The one about quality improvement comes from a good resource on quality improvement that most people would recognize, this Lyon article in Annals of Internal Medicine. And evidence-based practice comes from Melnick, who is one of the leading writers about evidence-based practice in nursing. So what you see in all of these definitions is that each of these activities has something to do with data, and it's each systematic, and you're trying to draw conclusions from them. And I think that's true for all of these different terms, which is why it can be so hard to figure out which is which. What I argue is that all of these approaches, research, program evaluation, and quality improvement, are examples of science. And science has three consistent goals, regardless of what you call it from a regulatory perspective. Science is interested in describing what's happening in the world around you, in predicting what's going to happen next, and in trying to influence it or exert some form of control over what happens next. So this is my daughter in second grade at a school science fair. I think that what we're doing as scientists is not very different from what an elementary schooler might do in a science project. We're trying to answer questions about the world around us. There are some fine nuances, distinctions that differentiate from a regulatory perspective whether we call something research or evaluation or quality improvement, but they're all systematic, they all use data, and they're all trying to achieve these same three goals. Here are some strategies that have been suggested for differentiating between these different types of science. I'm going to argue that three of them have often been used but don't work particularly well: generalizability, quality of the methods, and whether or not something was published, and that four others really come down to the question of intent. Why did the investigator do the study in the first place? And if you can answer that question, you can be pretty confident about whether something is research, evaluation, or quality improvement. So here are the three that I think don't work. Generalizability, I think, is one that you see all the time. It's in the federal definition of research. If you look at our own IRB on campus, COMERB, if you're trying to get something approved as quality improvement, you have to check a box, and it says this is not intended to produce generalizable research. But the question is, what do we mean by generalizable? Some research isn't really generalizable. You know, we have things that are qualitative or community-based participatory studies, and they're really intended just to tell you what's going on in this particular group right now. There's a lot of studies, drug trials, large-scale clinical trials kinds of things, that are deliberately using sort of artificially selected patients. We'll talk more about that when we talk about populations for research. The idea there is you don't want patients who are too complicated, who have a lot of comorbidities, who have alcohol problems or drug problems, who have mental health issues, who don't come back for their appointments. In other words, real patients who you might see in practice. So is that research that's conducted with sort of artificially healthy patients, is that generalizable research? We're not sure. And then we have research, what we would call research for comparative effectiveness, that these days is starting to look a little bit more like evaluation or quality improvement. It's relying on large-scale, big data kinds of investigations. It's trying to draw conclusions about populations, not about small samples. And you know, if you have a really good QI project, you discover something works well in practice, that actually might generalize to somebody else's practice setting somewhere. So I think generalizability is probably better thought of as sort of a continuum, limited scope to broad scope generalizability, and QI or research could fall various places on that. But you should know that on our campus, because of this IRB rule, this is a regulatory issue, do not use the word generalize or generalizable with a quality improvement project, because that's part of how they get around quality improvement projects, is they forbid you from using two words, research and generalize. Methodological quality is another way. People would say, well, QI studies just aren't as good as research studies. Often there was a lack of control groups, there was a lack of randomization between groups, the statistics were relatively simple. I think that is also changing over time. And quality improvement is getting more sophisticated. People are looking at more sort of complicating factors that require more advanced statistics. DNPs are getting more training in sort of how to do science well. Other people who do quality improvement. And the issue of comparison groups we're going to talk about when we get to research design. I think randomization probably is a thing you should not do in quality improvement. Comerb and I actually have a difference of opinion about that. But other ways are available to create a comparison group that make your quality improvement study more rigorous, more convincing to other people. So those are the kinds of things I think you could think about. And then finally, publication. The argument has been, well, if you're published, it must be because you want to generalize, to contribute to the knowledge base, that sort of thing with research. We could have an argument about that. The average time from a new study being published to being applied in practice is 17 years. Is that really affecting practice if you publish a research study? Evaluation. The goal is to demonstrate the value of a particular program, to find out whether it was a good investment of public or private resources to offer this program. Quality improvement. The goal is to get better over time. Now, those sorts of things might be interesting to other people. Obviously, the thing about value, if it's a public program and you pay taxes, you're interested in whether there's value to the program, whether it's accomplishing its goals. I would like to see those published. If you're talking about quality improvement, if you're doing quality improvement work someplace else and there's another clinic with similar demographics out there that's already tried the thing you're going to try, you'd like to know how that went, what worked, what didn't. So there's an importance to sharing your findings, your lessons learned. And this is why I'm saying limited versus broad scope generalizability. Now, just a word about the square peg kind of issue. We have had DNP students go to publish their results, and they sent it to a journal that usually publishes research, and the journal wanted them to use words like research question or research methodology, and I said, well, this isn't research, this is quality improvement. And the journal said, well, those are just the headings we use in our research articles. And that's not actually easy for the journal to change. Those sorts of things tend to be consistent over a period of years, what the headings are and that kind of thing. So as the field is evolving, journals are getting broader, but some of them may not be able to work with you on that. And in fact, that particular DNP student had to withdraw that submission from that journal because Comerb forbade her to use the word research. It would have violated sort of her regulatory agreement with Comerb, and the journal couldn't bend on calling something research question or research methods, so they had to decide, okay, this can't go to this journal, and it did eventually get published someplace else. Here are ways that I think you actually can differentiate between quality improvement, program evaluation, and research. There are 4 of them, and they all sort of converge on this issue of why did the investigator do the study in the first place? What was their intent? So in quality improvement, there is a high level of involvement by the organization that you're working with. Really, it's to achieve the organization's goals. Evaluation, it may be the people doing the program, or it may be outside people who are funding it. Research is about your interests. So if it's your interest, your question, you're doing this because you want to know the answer, it's probably research. And your audience is not really the people who are in the study at all. It's people who are involved in the same field elsewhere, who are your peers. Randomization, I do think, is a key differentiator between quality improvement and research studies. The reason for that is to do research ethically, you have to have this position called equipoise, which means you don't know if the treatment is better than the control group. Otherwise, it wouldn't be ethical to flip a coin and give people one of those things. If you're pretty sure the treatment works better, you ought to give it to everybody. You're withholding it from the people in the control group. So the way that science has worked with this for a long time is to say, well, there is no previous randomized controlled trial, therefore we don't really know anything about it. So we can't promise you any benefit, we're just going to let you opt into this, here's your informed consent. So I think random assignment is a hallmark of research. And if you're using that methodology, we might say it's research. Now, COMERB will let you use random assignment and call it quality improvement still if you sign on to this agreement that says I won't call it generalizable and I won't call it research. To me, that seems a little far to go. But quality improvement and evaluation are just looking at something that's already being done. And the idea is it's better to do it and evaluate it than to do it without collecting data. You're trying to create an environment of better care that's ultimately going to benefit directly the people who are in the study. A third way to look at this is whether something is offered as the standard of care. In research, again, it's optional. The participant has to say, yes, please sign me up for this. I know I may not get anything out of it. In quality improvement, you do it for everybody at the clinic, everybody who meets the eligibility criteria, regardless of whether they opt in or not. Maybe you give them a chance to opt out if they don't want it, but maybe not even that. This is just the way you do care at the clinic. No informed consent is required. And then finally, the role of theory. I've argued that theory is the hallmark of research because you're not interested in this specific program. You're interested in what it means overall about the world, about the nature of humanity, about the nature of healthcare. Evaluation, you're trying to make decisions about whether or not to continue a program. Quality improvement, you're trying to make it better over time. So IRB review is just one regulatory process that draws a distinction between quality improvement and research. This is often why people want to know, is my study QI or research? But it's really based on what are the laws that govern these two activities. The ethics are always the same. We want to be respectful of people, we want to treat them well, we want to treat them fairly. That's a professional obligation no matter what kind of science you're doing. An IRB is a mechanism that enforces those ethical standards, and it only applies if you are at an institution that receives federal funding and you are conducting something that would be considered research. So if you have human subjects but your activity is quality improvement, there's an exemption for that in the laws about human subjects. If you're conducting quality improvement, there's an exemption for that in the HIPAA laws. You don't need somebody's special consent to look at their records. It's kind of a unique situation because the goal is to improve care and to benefit the individual people who are involved in the study. So here at the University of Colorado, our IRB has changed over time. They used to say, if you're going to publish, then it was research and you needed IRB review. I've tried to show why that's not true. Then they went to a checklist and it said it has these elements, not those elements. Randomization was one of them, but it certainly wasn't the only one. They decided that was too complicated. So number 3 is they asked, do you consider your project QI and evaluation? If you said yes, they said, here's an additional checkbox. Do you agree never to call it research and never to use the word generalizable? And you said yes, and then you were done. And they said, okay, you're approved as not human subjects research. Basically, they're saying we don't have jurisdiction over your study. Now what we do in the College of Nursing is we self-certify, and many of the hospitals, Children's Hospital has something called ORCORP that does this. The University Hospital has a group that reviews QI projects. So the institution that you're part of can say, yes, this is indeed a QI project, it is following ethical standards, it does not have to go to the IRB, and the IRB says that's okay. So out of all of these different approaches to science, we're trying to build a body of knowledge that helps us take better care of people. At the one level, we have quality improvement, which is about improving an individual program, getting better outcomes for the specific people involved. At the level of evidence-based practice, we're trying to roll up many of those individual patient experiences into a broader rule about how to help people. And you can use evidence-based practice as part of a quality improvement project. So if you're going through our Bridge Committee in the College of Nursing, the Bridge Committee will ask you, here's this intervention you've decided to offer as a way to improve quality. What's the evidence that that works? Where's the meta-analysis? Where's the Cochrane review? That can't be just based on your clinical opinion. If you're evaluating, you're making a value decision. Should we continue or discontinue this program? Is it cost effective? Is it a good use of resources or not? And then research, we're testing theories that aren't necessarily about the specific people involved in the study. They're about a generalizable rule that could be applied to other people at other situations, something that tells us about health or people or health care more generally that would apply very broadly in the world.